Today we're going to be talking about supraventricular tachycardias, or SVTs as we'll be referring to them during the podcast, just for ease of speech really. And I suppose we should start by defining what we mean by SVT. Technically an SVT is any arrhythmia that arises from higher than the bundle of His. So essentially any arrhythmia that is from the atria. This therefore means that atrial fibrillation is an SVT, which people often don't think of. Atrial flutter is also an SVT by definition. But obviously you've probably noticed in clinical practice when we use the term SVT, it's quite specific to a narrow complex tachycardia. And typically what we use the term synonymously, SVT, and actually what we're really meaning is an AV-NRT or an AVRT. And these are two specific conditions that involve re-entry mechanisms causing a tachycardia. Joe, how do these SVTs present?
Well, I guess the first thing that we really need to think about is what sort of things trigger a supraventricular tachycardia. So that might be something environmental, that might be a use of something. And so things that I think about when I'm presented with this sort of situation is commonly these are young people, right? So has this person consumed something that may have led to them getting and presenting with a supraventricular tachycardia? So overconsumption of caffeine potentially, or overconsumption of alcohol. Typically we may see this in patients who may have used recreational drugs, particularly amphetamines, but also in drugs that may be prescribed to them. So significant use of beta agonists, specifically beta 2 agonists like salbutamol, can cause someone to flip into an SVT. And also in healthy individuals, just undertaking exercise can actually again flip you into that SVT. So it's good to explore that within the past medical history or the history of presenting complaint as to kind of what has led to this triggering of an arrhythmia.
It's good to hear exercise is bad for you. I'm quite glad that you've said that. It makes me feel better about my life.
Also thinking about significant family history of arrhythmias, and we always want to be asking that question to the patient, asking about any sudden adult or child death within the family is really, really important. And may trigger you to think a little bit more about what's going on and a little bit more about referral or urgent referral to cardiology from there. So I think, triggers can be something just as simple as a consumption of caffeine, but actually also it could be a congenital trigger that's just presenting at this moment in time. So it's important to keep all of that.
I did note you picked up your tea at that stage.
Yeah. I'm being prompted to put myself into an SVT by drinking tea during this podcast.
That is dedication to the cause.
Yeah.
I'm very impressed.
I'm on my way to atrial fibrillation with my caffeine consumption. But anyway, moving on from my personal consumption of caffeine, what sort of features or signs and symptoms are we going to be seeing our patients presenting with?
So typically the main symptom that patients will complain of is palpitations. And these are typically rapid onset, constant palpitations. They feel like their heart's about to explode out of their chest. It can cause other symptoms such as chest discomfort, can cause shortness of breath. In older patients who go into SVT, it can cause similar sort of anginal type symptoms. And in terms of your observations and things, it's obviously going to give you a tachycardia. So normally a heart rate above 140 to anything between sort of 240 really. And it can cause syncope as well. Joe, you're our resident ECG teacher of the medical school. What do we look for on their ECG?
Thank you for putting my feet to the fire.
I think that's a great little segue to make Joe think on his feet.
So how do we then differentiate, especially on an ECG, between something that's sinus tachycardia? So does this patient have a sinus tachycardia from exercise? Do they have an infection? Do they have something that's non-SVT related? And actually, if I look at a patient's heart rate and I look at it and it's sort of over 150, 160, I'm starting to really question whether that is a physiological tachycardia and whether actually this patient's suffering from an arrhythmia. So I think that's probably one of the first things that you need to have a look for on an ECG. So once you've had a look at the heart rate, the next thing that you want to look at on that ECG itself is this ECG regular or is it irregular? If you've got an irregular, narrow complex tachycardia, specifically if it's irregularly irregular, then that can differentiate quite easily between your kind of typical SVT picture with a AVNRT or AVRT and something more common like a fast AF. So atrial fibrillation with rapid ventricular response. So you want to look at the regularity of that ECG. Sometimes, particularly with junctional tachycardias, those that are within the bundle of his, the P waves aren't always actually visible. And so, but that's also the case just purely sometimes because of the speed of the ECG, the speed of the heart rate rather itself. P waves aren't always visible. So something that is regular, absence of P waves, but something that is also narrow. And when I say narrow, I'm looking at the QRS complex. So if that QRS complex is below 120 milliseconds or 0.12 seconds, whatever you use, then
three small squares.
3 small squares. So we like small squares as well. So if it's less than 3 small squares, that can really increase your probability that this is a supraventricular tachycardia and it's not something else. If you've got any signs outside of that, you really need to start thinking about other alternative diagnoses, particularly if you're getting a widening QRS complex, more indicative of a VT, something that's irregular, as we said, more indicative of AF. And these are all very important differentials to consider because your treatment algorithm for a wide complex tachycardia is very, very different from a narrow complex tachycardia.
Definitely. And certainly a lot of patients, once they get a bit older or if they've had a previous MI, will have a pre-existing bundle branch block, which obviously gives you a broad QRS complex. And when these patients are susceptible and they can go into SVT, and when they do, it is often tricky diagnostically to work out, is it a VT, is it an SVT? Which arm of the ALS tachyarrhythmia algorithm are we going to go down?
Yeah, I think really in that sort of setting, from my practice, I would always look at a wide complex tachycardia and consider it as thus until proven otherwise. And because it is very, very difficult to differentiate between an SVT with what we call aberrant conduction, whether that's because there's a left bundle branch block or something else going on. So I would always consider it to be VT and play on the safe side until proven otherwise, until I'd probably escalated to a senior.
Yeah, definitely, I agree, 100%.